Good afternoon, everybody. We're going to give everybody a minute to get settled, and then we will get started with our monthly Virginia Governor's Conference on Aging webinar. All right, good afternoon, everyone, and welcome to the monthly webinar series hosted by the Virginia Governor's Conference on Aging. My name is Martina James Nally, and we really appreciate you being with us on the fourth Tuesday of each month. This webinar series was started due to the need to postpone our in-person conference originally scheduled for this past May. Our steering committee and partners found it really important to be proactive, and we pushed out our in-person conference to May 17 and 18 of 2021. But in the meantime, we designed this webinar series to keep an active engagement and conversation going between our presenters, our attendees, our sponsors, and our partners. This webinar has allowed us to share information that we had planned to share in person with you this past May, and it keeps us in touch with all of our partners as we move forward into 2021. Before we get started, I want to thank some of our sponsors and partners who have made this conference and webinar series possible. Without their help, we wouldn't be able to do the work we're doing, whether it's in person or virtual. Today, I want to highlight Dominion Energy, as well as AARP, who are presenting sponsors for the conference this year. They've been longtime sponsors and supporters of the conference since it was reinvented in 2016, and we couldn't do the work we're doing without them. Additionally, each month we highlight two of our exhibitors. This month we're highlighting the Virginia Assisted Living Association and Honoring Choices Virginia. They encourage us to keep doing our work, and we encourage you to take some time to go visit their websites and learn a little bit more about what they're doing. And we encourage you to visit them at our in-person conference in May of 2021. A couple housekeeping measures before we get started. We'll be taking questions throughout the program. We encourage you to type those questions in the question box. At the end of the session, we will go through the questions that have been submitted and share them with the presenters and get those answered. And we'll do our best to answer as many as possible. Post-webinar, you will get an email that will include not only a link to the recording, which gets posted within 24 hours of the webinar ending. You'll also get contact information for our presenters and a follow-up survey. With your feedback, we're able to design a webinar series as we move forward that really provides information that's important to what you're doing every day. We also hope that you will continue to mark your calendars for the fourth Tuesday of every month. We'll be talking about topics such as serving seniors in rural communities, addressing the holidays during a pandemic and dealing with social isolation. And also we'll be talking about supporting caregivers and our employees in the aging services in what is an increased stressed environment due to the pandemic. Those topics will take us through the end of 2020, and we look forward to planning what's to come in 2021. With that, I want to hand off the screen and conversation to this month's moderator, Marta Keane, who is the Chief Executive Officer of JABA, and she will take us into the beginning of the conversation with our two presenters regarding advanced care planning. Marta?
Thanks, Martina. It's a wonderful honor to be a part of this presentation. We have so many efforts across the Commonwealth and the country that are looking at how to address advanced care planning. This is such an important topic. Making a plan and communicating it to loved ones, it allows for peace of mind, both for each of us as well as for our families when it's time to make those decisions. And obviously, COVID has brought this to the forefront. Advanced care planning allows each of us to indicate our goals for end of life. We have two wonderful speakers today to bring information from their respective training of both law and medicine. And that's going to really help us understand for ourselves, for our clients, and for our community how to best bring this forward. So our first speaker will be Nathan Kottkamp. He's a partner in Waller's Healthcare Department, and he provides counsel on compliance with federal and state healthcare regulation and day-to-day operational issues. He is an undergraduate graduate with honors, high honors from the College of William and Mary, and then he graduated with his law degree magna cum laude from University of Pittsburgh, as well as getting a master's there in bioethics. So obviously at an early time, he realized he wanted to focus on healthcare. He's certainly been acknowledged across the state as a Center for Practical Bioethics. He received a Vision to Action honoree. Virginia Business named him to the legal elite for many years. And then Central Virginia Health Planning Agency, he received a health planning award. Probably one of the most significant things to share with you today is that he is a member of the Virginia Bar Association in the health law section, and significantly the founder and chair of the committee to establish Virginia Advanced Directives Day, which is a really key piece that may give all of you some ideas for planning in the future. And I know he's going to talk about that. And he's been a member also of the Advanced Directives Task Force Committee and the Supreme Court of Virginia Commission on Mental Health Law. And so we appreciate his being willing to participate today. Then we also have Dr. Angie Stiltner, who graduated from the University of Virginia with both her undergraduate and medical degrees. After graduation, she completed a UVA-affiliated family medicine residency and geriatric fellowship with Carilion Health System in Roanoke. Then post-fellowship, she was full-time faculty at University of Virginia, working in geriatric medicine. And she's also a visiting UVA associate professor of family medicine so that she can continue to teach medical students, residents, and fellows in her current role with the Hospice of Piedmont. She's been with them since 2011 and the senior medical director since 2014. She's board certified in family medicine, geriatric medicine, and hospice and palliative medicine. She's been one of 8 national scholars selected for the Hearst Foundation's Leadership Scholars Fund through the American Academy of Hospice and Palliative Medicine, and a member of the American Association for Physician Leadership, enrolled in a program for certification as a physician executive. She's also the founding chair of a National Pharmacy and Therapeutics Committee through Delta Care RX, and that is a national initiative charged with providing a collective national voice for safe, precise, and age-appropriate medication management at the end of life. So and the past president of the Albemarle County Medical Society. So you can see we're very lucky today to have people who have a lot of background and commitment and passion for this topic. So with that, I'm happy to send the camera and the over to Nathan.
Thanks, Marta. I think I just need controls. Hopefully you can see it.
There we go.
We can see it? Perfect. Okay, well, again, I'm Nathan Kottkamp. I spent a lot of my time talking about ethics issues and advanced care planning. Really appreciate the opportunity to chat with so many of you today all across the state. So I usually start out talking about what advanced directives are and what they're not, what advanced care planning is and what it's not. With any luck, the folks out there, I can't see your faces, but I'm going to guess demographically that you know what one of these is. Unlike my children who would be baffled by this thing, it's a compass. And as we know about compasses, it shows us one very, very important piece of information, which is the direction of north. We don't have a lot of things that sort of relate to this these days. We're so used to GPS and giving, 500 feet until you have to make the right turn and the left turn and this and that. So it's sometimes a little disorienting to think that something as simple as a compass can be life-changing. And that is how I think of advanced directives and advanced care planning. It's not like a GPS. We don't know every turn to make. We don't know. It's impossible. No one's got a crystal ball. You can't write down all the choices that you'd want, because you can't predict what kind of healthcare you're going to need. But having the fundamentals, having some of the real guideposts of what makes life meaningful for you, and what does it mean to be in pain? What does it mean to have interactions with your loved ones? Who is your decision maker going to be among your big, spread out, and maybe contentious family members? So these are the types of things that I consider to be the kind of pillar sort of information that's not unlike a compass. It's not perfect, but having that information is absolutely vital when we're trying to make decisions for a person who cannot speak for themselves. So as a lawyer, I always have to talk about the law, at least a little bit. There is lots of law that both authorizes and requires advanced care planning. The Patient Self-Determination Act of 1990 is the federal law that formalized the ability to have advanced directives. Unfortunately, one of the implications of that law is that it left it up to the states to decide how it is that each state is going to go about implementing that law. And so that's the reason we've got essentially 50 different state laws as it relates to the requirements. So we've got some states that require a notary, and some that require specialized language, and others that are much looser. So unfortunately, for a guy like me who really wants to broaden the reach of this and to reduce confusion, the fact that we got 50 state laws makes things really, really complicated, but we do try and cut through that with some other mechanisms. There are also requirements, regulations, and then accreditation requirements for asking about and offering advanced directives when people come into the facility. This is why you get asked if you go to the emergency room. It's not because they think you're going to die right there on the spot. They're required by federal law to do that. It is both a good and bad thing. The way that it's oftentimes handled is by a intake person, a registrar clerk, who probably has no experience, no training, and it's really not a great time and a great way to ask about advanced care planning. So it's really incumbent on all of us that are involved in the healthcare delivery to see that that's not the only interaction that individuals have with advanced care planning. It needs to be integrated into the nursing intake questionnaires and the history of physicals and right down to annual physical exams in the outpatient setting. So we've got lots of places that advanced care planning really ought to come into play. The law isn't the reason that we're doing this. As was mentioned, I have a master's in bioethics. I was going to go do that long before I had any inkling that I was going to be a lawyer. So, and I had been involved in advanced care planning before that. So I know that it is the right thing to do. It's for all adults. I think one of the things that there's a misperception in the general public that advanced care planning is only for older folks. It's only for folks that have cancer or heart disease or lung disease, something that puts them at a higher risk of dying on the rather soon side, however you want to classify that. And the other misconception is that it's about putting down your wishes so that you don't have to get put on machines, and you don't live out life in permanent vegetative states or things like that. And the reality is, it's about any kind of choices. From my perspective as an ethics guy, it's just as important for the people that don't want care as it is for the people that do want care to have their choices honored. So that's one of the most critical pieces of this, is describing whatever it is you want, and it's very personal to you. The other thing is that it's a gift to your loved ones. And I know this from personal experience in serving on ethics committees, and when people come up to me at public presentations about the fact that they're still tormented about the decisions they made for their mother, their father, their brother, whoever it was, 5, 10, 15, 20 years ago, and they still agonize over whether they made the right choices. And to think that you have the capacity, we all have the capacity to at least make those kinds of decisions easier for our loved ones. It may not be perfect, but to make things so much easier to give that gift of understanding it's just one of the most incredible gifts you can give to your loved ones. So how are we doing in terms of, we've got this law that's been around and created these rights for us since 1990. We have events like National Healthcare Decisions Day that I've been involved in, and we've got websites all over the place and lots of initiatives, and yet the numbers are really pretty paltry. We're somewhere between like a quarter and a third of all people have an advance directive, and that's really about it. Yeah, we're going to talk a little bit about the implications of that and some of the reasons why in a few minutes, but it's just low numbers. So keep in mind the opposite of that is that most people don't have one, and it ends up being a challenging situation of making decisions. I think one of the more troubling things is that even when we have situations where folks have advance directives, the indicators are they're not being well used. And so I recognize this is an old study, it dates all the way back to 2003, but every time I talk with healthcare providers, they always shake their head and they say, yeah, I think this is probably right. So in this study, they found that less than half of the people who were in severely terminally ill situations, the very same people that you really want to be having advanced care plans, less than half of them had one. Of those that had one, only about 12% had any input from their physician. I get that, that's fine, that doesn't really bother me too much. But the one that really, really gets me worked up is that between 65 and 76% of the physicians whose patients had the advance directive, so they beat the odds, they did what they were supposed to do, but their providers didn't even know it existed. So obviously it was useless. So we have to change this. We have to do a better job of integrating these important documents and this important process into the delivery of care. So I'm not going to spend too much time on this, but just to know that the various studies indicate that when people have advanced care plans, in the case of cancer here, they're more likely to receive the care that they wanted. Here's another one where, to a non-medical person, this is perhaps totally baffling. So here you've got Mayo Clinic, one of the top hospitals in the entire world, doing these invasive cardiac procedures, so literally threading a needle into your heart, which step back and you realize, yeah, do anything to somebody's heart and they could die right there on the table. And only 40% of the folks had an advance directive, which is just astonishing. Like, nobody should go into that procedure without having an advance directive from my perspective. So why are the numbers so low? Well, a lot of us just sort of bury our heads in the sand. We're scared and we're squeamish, we're in denial, we're confused. We as Americans, for the most part, don't have a good vocabulary for this topic. It's not an excuse, it's sort of just an explanation, but we have to do better. The mortality rate of humans in the United States is 100%. The percentage of folks that have a situation at some point in their lifetime where they cannot speak for themselves is way, way, way over the majority. I think it's something like 80%. So it doesn't have to be end of life situations either. And that's one of the things we need to be mindful about, is that it could be a car accident. It could be a stroke. It could be COVID, where you're incapacitated for a few days while you're on a ventilator. All of these are situations where we don't want to go into it making decisions based on guesswork. We're trying to figure out who's going to make decisions out of your big, complicated family. We want to know what you want. We want to know who's going to speak for you. And so that's the reason that we're doing this. So one of the reasons that the process seems to fall apart, at least in what I've seen, is there always seems to be someone expecting somebody else to take up the mantle. And so physicians think that nurses or other staff are required to do it. Patients are waiting for their physicians. Physicians are thinking that if something's important, their patients are going to say stuff. Families and they want to defer to the patient. I mean, you just put all these variables together and you see that it all falls apart. And the easy way to fix that is pushing it all together and everybody asking on multiple occasions. And it's way easier to say, we've handled this, than to guess and find out that no one has handled it. This is the other problem. And I blame my profession for part of this situation, and part of it's the federal law too, the fact that we have 50 states These are complicated documents because they become so legalized, and there's so much legal gobbledygook in them, and there's these requirements for notaries and special language and things like that that were confusing people. These should be simple documents. They should be plain language, easy to read and understand documents. And so at least for myself, I try every time that I'm working on them in various task force to be sure that we're trying to make them as simple as possible, because they shouldn't be as complicated as this may. In Virginia, when you don't have an advance directive, and so this is, again, the majority, maybe is upwards of 80% of the population, we do not have a situation where we just make decisions for somebody else. We have to find another person to do so. And we use a pecking order. This is the pecking order that we use in Virginia. We start with whether or not the person has a guardian, somebody appointed by the court. Very few people have those. Then we turn to the spouse. And this applies, by the way, unless a divorce action has been filed. So we have plenty of people that are, they call themselves legally separated, or they're just living separately because they're doing a little test trial of not being in the same house. That's still spouse. It's still married under Virginia law. Then things get really complicated, though, because we go into the realm of multiple people can all classify as being in the same category, and there is no preference. So all adult children, it's not the firstborn, it's not the first male, it's everybody. And we expect, the law requires that we find a majority, which is maybe fine if we've got an odd number of children, but oftentimes it's 2 children and they can't agree, or it's 3 children and everybody's got a different decision. So it gets very complicated. And otherwise we go to parents and adult siblings and any other blood relative. And we do have a mechanism for like the trusted neighbor or friend, but those don't go down to the level of non-end-of-life decisions. And sort of the other thing is that even if you don't have an advance directive, if you can write down your wishes, that's better than nothing, and we'll take it in Virginia. I talked about trying to make things easy. I think I'm so terribly sorry. I think I'm missing a slide by accident, but I'm going to tell you this because it hardly even needs a slide. In Virginia, the requirements for making an advance directive are incredibly simple. You don't need a special form. You don't need a notary. You don't need to pay a lawyer. You don't need to do anything other than put your wishes in writing, sign it yourself, and have 2 adult witnesses sign it. That's it. It can be on a piece of just notebook paper if you want. It can be on a cocktail napkin. If it expresses in some way that I and others can understand what you're trying to talk about, and you sign it, you got 2 witnesses, you are good to go. You have an advance directive in Virginia. I like to point out this little fact about decision makers because I spend a lot of my professional practice dealing with HIPAA, and I see that HIPAA is misinterpreted on a routine basis. And one of the things that is very unfortunate is that authorized decision makers oftentimes don't get the health information that they need to make decisions for somebody else, and that is absolutely not the way that HIPAA works. If I am appointed as my wife's decision maker, I absolutely have to have information about her her condition, her care needs, and things like that in order to make decisions. So if you ever hear someone saying, well, we can't give information to the individual's power of attorney because there's no HIPAA document that authorizes it, that's ridiculous. Make sure that you're talking to the HIPAA privacy officer at the facility, because that's just not the way that the law works. I mentioned that I am the founder of, and it's been mentioned that I'm the founder and chair of National Healthcare Decisions Day. That event comes on April 16 every year. It is the day after tax day, very purposefully. We sort of riff off of the Ben Franklin little quip that nothing in life is certain but death and taxes. And so we've selected a single day as a recognition day to encourage facilities and healthcare professionals and chaplains and lawyers and professional planners, financial planners, and all sorts of others, religious organizations, to use that day as a collective effort to highlight the importance of advanced care planning and advanced directives. The point is not to require folks to do things in any particular way, but it's really to just get a collective focus on advanced care planning issues, much in the same way that we have, you know, Go Red for heart, or the pink for breast cancer. We're just trying to pack it into a single day that we can use as a catalyst for people to understand how important it is, to push them over the edge of it's never the right time, it doesn't feel right. It's an opportunity to say we all need to do it, anybody over the age of 18, and hopefully people are doing that already in this age of COVID and recognizing that it can strike anybody at any time and put them on a ventilator. And we certainly want to know who their decision maker is. But the reality is we know that people have a hard time with it. And so that's the reason this event exists. I want to encourage you to try and help us. It's completely a grassroots initiative, and you can lead by example. We have, as of right now, 166 individuals on this webinar. We don't have a polling function, and I wouldn't want to embarrass people anyway, but my guess is we don't have 166 people who are joining us today that have their advanced care plans in place. And even if they did, my guess is they don't have one for their parents, they don't have one for their adult children. And so this is the opportunity to do it for yourself, do it for your loved ones, make sure you make copies and share them, things that I think Angie's going to talk about in just a minute. But talk with others, volunteer to speak in the community. This is a topic that is not that hard to talk about. It can come up in church groups and civic groups and book clubs and all sorts of different things. Collaborate in the community. If you're with an organization, team up with others and make this a community event. It's a really wonderful opportunity to put together some connections that may not otherwise exist in the community. And share the resources. Again, it's nhdd.org. It's there throughout the year, and hopefully it will offer you some tools that can help us move that number so that we're at least at 50% of the population having advanced directives. The last thing I'll just say about it is very, very significantly in Virginia, this isn't the case everywhere, but in Virginia at least, you can use an advanced directive to also talk about mental health things, dementia, organ donation, amputations, blood transfusions. It doesn't have to be end of life specific issues. It can be anything related to your care in situations when you cannot speak for yourself. And so with that, I will turn it over and look forward to chatting with you in the questions portion.
While we're waiting for this to come up, hopefully it does. Thank you both, Marta and Nathan, for that wonderful introduction. Look at this. I hope that this is going to pop up here in a minute for us. Thank you so much. It's such an important topic. I am so excited to be here today. I'd like to thank the Planning Committee for inviting me to join in this conversation, and just how important it is, as we've laid out, for all of us to start this conversation for everyone, for our loved ones, for ourselves. Are you guys seeing my presentation yet?
Yep.
Yes, we can.
You are? Okay.
Presentation mode.
It's not in the right mode. Let's see. Oh, let me switch that other thing. Sorry about the technical difficulties here, folks. Thought we had this laid out. So it's not working.
I would just say, Angie, we can see it. I know it's not the perfect.
Okay.
Slide
Yeah.
mode.
Angie, go all the way over next to where, underneath where it says file, it says from beginning. Just click that.
From beginning. Okay. Right here.
Click that. Yep.
It's not doing it. Interesting.
Well,
Sorry, folks.
I know
All
you
right,
have
that's
a lot
it.
to
I'm out.
cover, so just go ahead with it. I think we'll be able to see.
Let me try this. You seeing it now?
Not at all. We were better off before.
Okay. Let me try again.
Would you like me to share it from my end?
Yeah, could you do that? That'd be great.
I'm
Uh,
on.
I'm not sure what happened.
That happens.
Sorry, folks.
Give me 1 second to switch PowerPoints.
It's up.
All right. So
Okay.
Angie, if you just let me know next slide, I'll do that for you.
Okay. Well, again, thank you guys for asking me to be part of this. It's such an important conversation for all of us, as Nathan has so eloquently pointed out, that anything can happen to any of us at any point in time, especially in today's time. We know with the pandemic, but anything, an accident. So it's important that we all, share in this and understand it. So I hope today to leave you feeling empowered and inspired. I think for us to move the needle forward on getting more people in our communities to do these and complete these conversations, have the conversation, start the conversation. We all need to get out there. It needs to be a grassroots effort in all of our communities. So I hope you feel empowered and inspired to do that today. So next slide. So, I thought I would share a little bit about what I see day to day, and I know many of you do. This is about real patients and their real outcomes. And obviously, we're all in this for the right reason. We want those to be quality outcomes. So we're looking at this patient. I thought I would start with a brief case here just to kind of set the stage for obviously how these things can end up. So we have this lady here. She's 90 and she's a resident of the local nursing facility. She's been there for the last 5 years. The staff actually sent her to the emergency department because she had new onset fever and cough. The ED physician, she was there by herself. She was actually very somnolent, unable to participate in the conversation. There was no advanced care planning or code status sent with her. And the facility, when they called the facility, informed the ED physician that she was a full code and her daughter in Texas was listed as her responsible party. They had no documentation on file for advanced care planning. And when the ED contacted the daughter, she actually informed them that she didn't feel comfortable making these decisions. The patient also had several other children who were estranged from the family, and she just didn't feel comfortable because they had never had these conversations. Next slide. So as we think on that case, just think as we go through these slides a little bit, what it might feel like to be that patient and that daughter. And then take a look at what we have on this slide. So I'd like for you to take in the visual here, because sometimes people are very visual. And we need to all think about, what would you choose? What is a good death for you? Would you like to die in a facility, possibly hooked to tubes and lines and having monitors? And, this patient on the left appears to be in maybe an intensive care unit. Luckily, someone's holding the patient's hand. But as you can see, these types of deaths can be very complicated and complex at times. And it's difficult really to love on your loved one and get really up there and take. Many people tell me they're afraid they may knock a line loose. So they can't have those close connections at the end of life like they can have if they die at home. So the one on the right, obviously, you see a couple snuggling in their own bed in their home. There's a harpist there playing the harp for them. It just looks very comfortable and peaceful. So, I like to remind people that these conversations, yes, they're very difficult, but, you can start by getting to know your patient, getting to know, your family member, your loved one. What would they want? What do they value? And how do they define a good death? Because really that informs us about, what our patients want at the end of the day and how they would like to die and who they want to make those decisions. Next slide. So what do we know and why does this matter? I mean, obviously it's very important in what we do, and we do know that if you go survey Americans, about 80% or more of them will tell you that they want to die at home. They really don't want that facility death that we saw on the left in the previous slide. They really want the death that we saw on the right, at home, being able to be cared for by their loved ones. But unfortunately, what we find in the statistics is while 80% want to die at home, only 20% are getting that opportunity to do that. So that's pretty distressing. Many of them are dying in facilities. And the CDC has some statistics showing where the place of death is from 2000 to 2014, and that's what's on this slide. And I'd like you to focus a little bit on the center, the kind of light blue piece in the graph. That's actually patients dying at home. So as you can see, that's widened slightly over those 14 years. And I'm sorry, they had no more recent data. I was looking actually for that, and this is the most up-to-date that they had. But we haven't widened that very much. Still, many, many patients are dying in facilities. The other thing that we know, and I see firsthand, is a minority of patients are actually accessing their hospice benefit at the end of life. We know nationally only 48.2% of patients are accessing hospice. In Virginia, we're under the national average at 45.3%, and we rank number 37 amongst all the states as far as having hospice at the end of life. As a hospice physician, I think it's so important to get these patients earlier. So many of them die within a week of coming onto hospice, sometimes hours, sometimes a few days, and about a third of them die within a week, and a little over 40% die in 2 weeks. And if you think about all the good work that we do and our interprofessional team does, we really need more time. So I'd really like to see us also, as we talk and have these conversations and what they mean. I know it's not all about end of life, but how can we move that needle for hospice too? Because it really is a 6-month benefit, and they get more benefit if they have more time with us. Next slide. So taking a step back, I think for us to really understand where we're going, it's important to understand, how did we get here? What really set the stage? Many people wonder about, why are we dying more in facilities now than at home? And we've really just seen a cultural shift over time. People aren't dying the same way now as they died in the 1800s, early 1900s, when many people were dying, of acute illnesses in their own home. Maybe they had an infection. Many of those children actually got to witness possibly the death of their parent or a younger sibling. Death was just ingrained in the culture, and talking about death was not taboo. In fact, many people had those conversations, and they actually normalized those conversations. They would take pictures with deceased loved ones. It was just more a cultural norm at those times. Unfortunately, what we see now with great advances in technology, but it actually has created an expansion of our lifespan, which is great, but a reliance sometimes on technology, and many of us are dying from more chronic debilitating diseases. And at times, patients are maybe valuing quantity over quality, but they may not be what they actually want. So if we sat down with them and had these conversations, what does quality really look like? What does quality in their life look like? What are they valuing? And maybe they really don't want to have more treatments and tests and prolongation. I like to say that we've medicalized death because of our technology. So, how can we actually take that back to more of a social event and a medical event? And the other things that we've seen is that we see it on the big screen, right? We see it on TV. We see it on the movies, that patients can code in the field possibly, and suddenly they resuscitate them and they're just like they were. So I think there's a lot of, that going on as well, that patients sometimes don't have the right perceptions from what they're seeing. So those are some ways that we've really got to this point, and how can we normalize these conversations again? Next slide. So what do I hear and see at the bedside at the end of life? Obviously, I'm a hospice physician for many years. And, I see that if these conversations happen and they happen well, it can be very, very positive. And actually a way of, like, I think Nathan touched on this, loving, showing your love and your care for your loved one, if you've had those conversations and gave them that gift. So I've had, the good, the bad. Had a situation of a patient who had made it very well known to her family that she wanted to deactivate her pacemaker at the end of life, which isn't something we always do. They're not typically painful. They're not like defibrillators, but she had made it very well known she did not want the pacemaker active. So they called on us and said, would you be able to make this happen? Mom really doesn't want this going. And so I was able to go out, have a conversation with them and her, and she definitely shared that's what she wanted. We made all the arrangements, were able to deactivate her pacemaker. Family was sad, but really in the sadness, they were happy because they knew they were honoring their mother. They were showing her the greatest gift of love by being able to say, we're going to be okay, and so that was beautiful. And in fact, she didn't die right away. It took a couple days, but she was very comfortable, and it was just the most loving event ever. And then on the flip side, we see, families, wondering, are they making the right decision? I wish I knew what she had wanted. I wish we'd had these conversations earlier. Those types of things. I wish we'd come to hospice sooner, just basically looking at, that they didn't know. So we had a patient on hospice, and this is a bad situation, and the patient just come onto hospice, and I think our nurse was just out there meeting them for the first time. And unfortunately, the patient had heart failure and stage renal disease, ended up coding at that nurse's first visit. And that was really, really distressful. The family didn't know what to do. Those conversations had not happened, unfortunately. And they called 911. The patient they attempted resuscitation, and the patient died on a stretcher in a very undignified way. And we saw a lot of, moral, just distress in general in the family. And I would say our caregiver, our hospice nurse suffered. Many of our team members suffered with the fact that the way this patient died in such an undignified way. That's not ideal in any way. And that's another reason why I think we need to get the patients on sooner, because many of these conversations have not even occurred when they come to hospice. And we want to help them, not have this complicated grief and suffering after a death. Next slide. So how do we do this? How do we move from high tech to high touch medicine? I think we need to all understand it's about patient and family centered care. It's not just the patients, who's surrounding them, who's taking care of them, and how we support everyone in that picture. And the fact that we don't have to just say it's either cure focus or comfort focus. I say it's both. And there's the right time and that trajectory for that patient to focus in on comfort focused medicine, but it doesn't have to be mutually exclusive. The other thing is having the conversation. It's about advanced care planning. The advanced directive is the document that comes out of that, but we need to start those conversations. And I don't know how many physicians we have on today, but even if you're not a physician or a provider, please empower your providers to start the conversations. Medicare has recognized the importance and does now reimburse for that, actually. So it's important to do that. As I mentioned earlier, seeking to define a good death and helping patients to have those transitions from a hospital to hospice and home. Next slide. So one conversation can make all the difference. I don't know how many of you all have heard of the Conversation Project, but it's a wonderful resource out there. They actually did a national survey in 2018 to find out how many people felt like it was important to talk about end of life and have these conversations. And 92% of people did think it was important, but unfortunately only about a third actually had done so. And what they also found was that many times what was holding them back was that they were afraid of upsetting their loved one, was one thing mentioned. But if you look on the flip side, if you ask the loved one, they really wish that someone had started the conversation with them. And about 95% of people are actually willing to talk about it. So we know that people are waiting to have these conversations. So it's time to actually start that. Many resources are available out there. The Conversation Project is just one of them. But they have wonderful documents on there to guide you. They have a conversation starter kit that you can use in multiple languages. They also have a lot of resources for patients with cognitive impairment and dementia, like our patient in the beginning. So it's a wonderful resource. Martina,
can I just chime in? I'm just going to chime in to say the Conversation Project is the host of National Healthcare Decisions Day too. So I'm just a huge fan of them. So thanks.
Awesome. Martina, would you be able to do I wanted to show a brief video to highlight these conversations are really difficult, as we all know, but very important. And I think this video they've done is wonderful at highlighting, how we can get there. Are you able to play that, Martina?
I'm trying to see if I can get it up here. Well, hold on 1 second.
Mom, Dad.
Let me do this real quick, Angie. My apologies.
No worries.
Right, we should be able to see it now. Let's see. All right.
Mom, Dad, sweetie.
Martina, I can't hear it. Can everyone else? No.
I'm getting younger.
So Angie, let's do this. Let's include the videos in the follow-up email.
That's
We can
fine.
hear people.
Oh, that'd be great. Yeah, that's awesome. Let's just go back into the slides.
Okay.
I think it would be great if you guys are able to watch the couple videos. I had this one and another one later. I think that would be perfect. So if we could go back into slides. And next slide. So there are many options out there for advanced directives. And as Nathan also pointed out, that you don't have to have a formal document. In Virginia, you can write it on anything and have it witnessed. But obviously there's living wills, many different forms of that, 5 wishes, and many of them name a healthcare agent or power of attorney included on them. DD&Rs are a form of an advanced directive, which is a legal document as well. And there are many registries. I think Nathan did a wonderful job touching on the fact that physicians oftentimes aren't even aware of where the patient has one, for one thing, and secondly, how to access it at the time. So there are some registries that you can actually file your advanced directives, and you can have these on the slides. But I did want to, on the next slide, touch a little bit on the physician's orders for scope of treatment. Many states have started these projects, actually. Virginia has their own. I don't know how many of you have seen this, but it's called Virginia Physician's Orders for Scope of Treatment, or POST, and some of them are called different things in other states. But this is a legal document, and it is an order from a physician. This is actually much like a DD&R, transferable with the patient. So if a patient is in a facility, it can go with them. If they're transferred into the emergency department, can be at their side, easily, obviously available to that ED physician to know what their wishes are. We do typically say that this form is best used with someone with, more chronic debilitating illnesses, maybe with just, a few years of life left, not just hospice, but before that, because it does focus on what type of medical intervention level a patient would want. Basically goes through the DNR. It actually becomes a DDNR now. If they actually do not want to be resuscitated, they can do this form instead of the DDNR. It goes through their level of medical intervention that they will want, anywhere from like full-on intervention to comfort interventions, and ask a little about artificially administered nutrition. And this, as I said, is signed by their provider, so it does become an order in the chart. So I think that's a wonderful way for it to be honored. The EMS has to honor it, the ED physician has to honor it. So if it's there, it has to be honored. What I find often and even as a physician, is if they have a living will or an old advance directive they did. Sometimes that was done in the 80s, the 90s. You don't know, it's been 20 years. Is this really still what they would want? They haven't updated it. So that's another thing we'll point out. It's important to update these as we go along, and make sure with any major changes, new marriage, divorce, whatever it is, make sure you've updated your advance directives. But think about the post form, because it is a great way to capture those and actually have them be in order. Next slide.
Andy, I hate to point this out. We've only got about a minute or two left,
Okay.
so we can have some
No worries.
questions. So I don't know if you want to like flip through a couple of these and just pick whatever last one you might want to talk about. And I know
Yes.
we'll leave YouTube up there for people, so maybe Martina, keep going.
Yeah, so you can skip this one. That's the video that you can watch later. I did want to talk a little bit about our goals and aspirations. And this area, we want to get to where La Crosse, Wisconsin is. There's actually an NPR special about the town where everyone talks about death, where 96% of residents die with the advance directive. We know nationally we're not anywhere near that. And here in Charlottesville at UVA, we looked at charts and only 8% of people had an advance directive. Next slide. And so we need you. And as I spoke earlier, we really need you all to go back to your families, go back in your communities. You may already be doing this, but maybe kick it up a new level, because until we get all this grassroots across Virginia going, we're never going to tick that needle up. So here locally, through Jaba's leadership under Marta, she's done a wonderful job. They identified a need. Obviously, we have a huge need, and formed the Central Virginia Advanced Directives Collaborative to educate the community, engage, motivate, and have the conversation. So I'd like to go on the next slide and actually highlight some things that we have done through our collaborative that you could maybe take back in your communities. This was started in September 2019 out of an idea of the Ethics Committee at the Jefferson Area Board on Aging. We got more than 20 organizations, more than 50 individuals together. We started getting some fundraising. We were going to do a National Healthcare Decisions Day project in our local libraries to include educational resources. Unfortunately, COVID shut down libraries in April, so we were unable to do that. We have that postponed for later. We launched a website, which we'll include for you. We have many resources and a lot of education on there for everyone. We've got lots of community people sharing our website and our information. Local Fire and Rescue actually is doing some printed bags, including our information for more than 3,000 seniors in our community. I touched on it earlier, but we've given some handouts. Actually, we've got some laminated cards we're going to get to healthcare providers. We collaborated with our Armor County Medical Society, and so we're going to get some information to physicians regarding billing. And a huge win is that the EMR collaboration between our hospitals to be trading partners with Epic, so that if a patient shows up in one ER, they can look into the other Epic system here in our local community hospitals and see the advanced directive or DNR. Next slide. And this is just a list of resources we'll include. There's a lot of help out there for you, so don't feel like you're alone in any way. Please reach out. Next slide. Think about what you might have done differently for the case, and just kind of closing there. How would you have handled that differently? And if you want to share some ideas in the discussion, that would be great.
Thank you so much, Nathan and, and Angie. We, for something that's not always a laughing matter, that's a great slide to end on. I'm going to ask Martina to join us again. I know there's been several questions. It sounds like both of you have brought up some great points that have made people think of some things. So Martina, if you can bring up some key questions. And
absolutely. So let's see. I saw, does a handwritten note have to be notarized? I guess this is to your presentation, Nathan.
Nope, no advance directive in Virginia at all needs to be notarized. So whether it's identifying your agent or your proxy, whatever word you're using to describe the person who will stand in your shoes and make decisions for you, or your, we call it a living will, just those written instructions. Either one, the requirements, again, are very simple. put your wishes in writing, you sign it, 2 adult witnesses, that's it.
All right. If you completed an advance directive on a form that was signed while living in Georgia, will Virginia still honor it, or does it need to be redone?
As long as it's got your signature and 2 witnesses, we'll take it in Virginia. However, the secondary piece of that is if for some reason Georgia has requirements that are less stringent than Virginia. So for example, if in Georgia, you only needed a single notary and no other witnesses, it would be valid in Virginia. So it's either it meets Virginia's law, so signature plus 2 witnesses, or it meets the other law. And that's pretty much the case everywhere else too. So we oftentimes get the question of, is my Virginia one going to be valid in other states? And everybody's got a reciprocity statute. So the answer is it should be.
Okay, great. What can we do to encourage doctors to abide by ACPs?
I think it's important to encourage physicians. I think, just explaining to them the importance of this and how much it matters to the patient's quality of care and how they do and what happens to them. I think if they could really see that, the outcomes for their patients and the quality of care they provide really starts with having these conversations and how important it is. And also encourage them because it's now, reimbursed. So if they want more information on that, we're going to have resources available for that. And there's plenty of information out there, but their time is valuable, we know, but they can schedule actually schedule advanced care planning sessions as often as they need to have the conversations, and they can bill for that.
And I will also say that all it takes is being involved in one ethics consult, and you've probably consumed way more time than you probably consumed the entire year just raising this issue with your patients. It doesn't take that long, but boy, does it take a long time when things go bad.
We have a comment, more of a comment than a question. Laura Pilati with Honoring Choices Virginia asked that we share that their organization is available to provide free advanced care planning appointments for those residing in Virginia during COVID-19. They're actually providing these free appointments virtually. And as we mentioned, actually Honoring Choices Virginia was one of our exhibitors that we featured and said thank you to this month. So Laura, we will include that contact information in our follow-up email. Thank you for pointing that out. We have a question. How is hospice paid for?
So hospice is paid for and reimbursed primarily through Medicare. We are Hospice of the Piedmont's a nonprofit hospice, so you have for-profit and nonprofit hospices. Our primary reimburser is Medicare, which covers everything related to the hospice terminal condition as far as medications, equipment, all the interprofessional team coming out there. So everything's included through their Medicare benefit. Medicaid also does cover hospice, and many private insurers also do. If patients do not have insurance, because we're nonprofit, we take patients regardless of their ability to pay.
Great. Can families override a patient if they don't want hospice, but medical states they are in their last 6 months? Or a physician states they're in their last 6 months, excuse me.
Can families override, you mean the patient? Was that?
Yeah, that's what the question reads. Can a family override, I assume, a patient's decision if the patient doesn't want hospice, but a physician states they're in their last 6 months?
No, if the patient has decisional making capacity, they have to be the one to sign the consents for hospice care. So they wouldn't be able to override their capacity.
And similarly, that's one of the reasons to create an advance directive in the first place is that, let's say an individual's got a condition they suspect is going to lead to a situation where hospice is going to be appropriate. If they create an advance directive that says if I've got less than 6 months to live and it's recommended that I go to hospice, family cannot override that. That's, again, one of the real reasons that some people create advance directives, is they know that they disagree on a lot of things with their loved ones and that they would make a different choice. And so that's why a lot of people create these documents.
Our next question reads, do you have to be licensed or trained to help an individual complete an AMD?
I'll get into that. It's sort of a tricky question. If you're a lawyer, easy, no special requirements. If you are an employee of a healthcare facility, easy, no special requirements. Otherwise, you need to be trained. You need to be a trained facilitator in order to do this sort of within the general public. I will say that if you are involved in trying to help a loved one and you're sitting there at the dining room table and you're working through a document and you're trying to figure out what it all means, yes, there are some that may say that's engaging in the unauthorized practice of law. I seriously doubt it. If anybody gets in trouble with the Bar Association, you call me, and I have a stable of others that will help you with that pro bono case, because I don't think it's practice of law. So the simple answer is, in the confines of your home, go ahead and help your loved ones. In the context of something public, make sure to do it through an organization.
All right. Let's see. We have a handful of more questions, but I want to be aware of people's time. So actually, let's do this. Let's go ahead and finish up our closing remarks. I know, Marta, you wanted to close with some comments, and that there were some other things you wanted to share before we ended. As just a reminder, this will be, this is recorded and it will be posted. And Marta, what would you like to share as we close out?
Just that both Nathan and Angie highlighted the differences when there's somebody with dementia-related advanced care planning, and there are other sources available besides the ones listed. Washington State has one that asks for people to consider various stages of the disease, and George Worthington at DARS, Department of Aging and Rehab Services, can point you in the direction of many other resources available specific to dementia, which was a whole other area that we could probably get into. But I do want to thank Nathan and Angie. They've done a great job of giving us a lot of good information to think about, hopefully helping all of you think about why this is so important to pursue in your community through collaboratives or other ways of sharing this, and to bring in the appropriate professionals, lawyers and physicians at the right time to help people. I also just wanted to take 1 minute to remind people that we have these seminars, webinars planned out in October. On October 27th, we'll be covering unique challenges of social isolation during the holidays. November, it will be a week early because of Thanksgiving. November 17th, serving older adults in rural communities. And then in December, it's also a week earlier, December 15th, stress, how we should be understanding and supporting our employees and caregivers during a pandemic. And I think all of those you'll find interesting. And I thank everybody for joining us today. And hopefully with the resources and the contact information, you'll be able to ask any questions that we weren't able to cover. So thank you.
Thank you all. Thank you so much for joining us.